morning, everyone. This is Carly Hodgson at KHI. We'll get started in just a couple of minutes here, but we are now live streaming the meeting on YouTube. Good morning, everyone. This is Carly Hodgson from the Kansas Health Institute. I'll be facilitating today's meeting, and I show 8:30, so I'm going to go ahead and get us started here. Welcome to the Finance and Sustainability Working Group meeting. Our agenda for the day is what you should see shared on the screen here. I'll provide a brief overview of the agenda as well as some of the materials that you should have received from me in just a moment. But first, want to hand it over to Scott Abbott from the Revisor's Office for a quick statement on open meetings.
Thanks, Carly, and good morning, everyone. Just want to give a quick refresher on the guidelines and disclaimers that apply to this meeting to make sure that everybody stays compliant with the requirements of the Kansas Open Meetings Act. So due to health and safety concerns, members of the public are not in attendance at this meeting of the working group. The meeting is being conducted by interactive communication, allowing members of the public without cost to listen to the meeting using broadcasting on the internet. The live stream can be reached by visiting YouTube and searching for the Kansas Health Institute channel. The agenda and documents for this meeting have been provided by the Kansas Health Institute, and a link to the meeting materials will be provided in the description or comments section of the YouTube feed. Each member of the working group and staff will state their name and title each time the individual begins speaking or voting so that you can be readily identified by remote listeners or observers. All participants are required to ensure that microphones, phones, or other electronic devices are muted when not speaking so that the ability of remote listeners or observers to hear the proceedings is not impeded. Public comment will not be allowed at this meeting. During this meeting, the working group will not recess to a closed or executive meeting. Each motion, if any, will be clearly stated before the working group votes, and the chairperson will announce the results of any final vote. And a recording of this meeting will be available on the Kansas Health Institute YouTube channel after adjournment of the meeting for members of the public to review. And that's all I have. So Carly, I will give it back to you.
Great, thank you. All right, everyone. So we're going to dive right in. We have a full agenda today. Again, that's what's shared on our screens. So we'll get started with some brief introductions in just a moment. But we'll spend the bulk of our meeting discussing recommendations that have been previously developed by a variety of different groups. All of those recommendations having to do with the topic of workforce. So as a reminder, at the highest level, this group has been tasked by the Special Committee on Modernization and Reform of the mental health system in our state to contribute to a strategic plan. We've been assigned a handful of topics by that group, as well as the kind of previous recommendations that have been developed. Kind of from here out, we'll go one topic per meeting as we come together in this virtual space. And as I said, our topic for today is workforce. So we'll spend the bulk of our agenda talking about those workforce recommendations that have been previously developed. From there in our agenda, we'll revisit some of the barriers that this group brainstormed at our previous meeting related to the topic. And that will be our opportunity to develop new recommendations beyond those that had been drafted by previous groups. Then we'll have a few brief administrative updates and we'll adjourn by 10 a.m. As a quick reminder, the meeting commitments that the group has agreed to, we have said we're going to come ready to both discuss and compromise, as this is a consensus-based process. Our time is very short and have a lot of ground to cover, so we're going to work to keep our remarks succinct and on topic. We're going to jump in to ask clarifying questions when needed, and we will we'll start and end on time. You received a number of documents from me ahead of this meeting. Probably the most important one that I would maybe recommend that you have open for reference throughout our meeting today is the one titled WG1 Crosswalk Agency. So in that document, you'll see the crosswalk of existing recommendations that was put together by KLRD and shared with the special committee. But in addition to that, we've copied over the notes that the various state agencies made in their testimony related to each of those recommendations. So hopefully in that document, you'll see both kind of where we are as far as existing recommendations and the notes from the state about what pieces have been implemented or what progress has been made towards implementing those. The other documents that you received from me ahead of this meeting were the full versions of the agency testimony, just sending those for reference in case additional background is helpful. And then additionally sent over the full version of the mental health task force report, as there's a number of implementation items related to each recommendations that that group did go ahead and include in that report, again, just as background information. But probably the most important recommendation, or most important document rather, will be that crosswalk, that WG1 crosswalk document, as we will, again, be spending the bulk of our time discussing the recommendations in that document related to workforce. With that, I'll maybe have us do some quick introductions of working group members, just so everyone is aware of who is on the line. The first person I'm seeing up on my screen is Representative Carpenter.
Good morning, everyone. I'm looking forward to the discussion today. Representative Carpenter from the 75th District.
Great, thank you. Next, I see Charlie.
Good morning, folks. Charles Bartlett. I'm the adult director for services at KDAD's Behavioral Health Services.
After that, I see Connie. Connie, are you able to unmute and introduce yourself?
You're right. Am I unmuted?
There you go. Now I can hear you.
Okay, sorry about that. Connie Freeze. I'm with Blue Cross Blue Shield of Kansas City, Government Relations.
Great, thank you. Next, I see Dawn.
Yeah, I'm Don Jordan, retired, worked 34 years for the state, including a lot of work in mental health and developmental disabilities, and I'm a member of the committee.
Great, thank you. After that, I see Greg.
Yes, Greg Hennon with 4 County Mental Health Center. I presently serve as the executive director here.
Thank you. Next, I see Senator Alley.
Thank you. This is Senator Larry Alley from Winfield. I'm representing the 32nd District and pleased to be here this morning. Thank you.
Great. Then I see Representative Lynn.
Good morning, Megan Lynn, State Representative for District 49 in Olathe.
Great. And after that, I see Sarah.
Good morning, everybody. This is Sarah Fertig. I'm the State Medicaid Director with KDHE.
Very good. And then I see Dr. Warrens.
Hey, Will Warren, Sunflower Health Plan in Lenexa and across the state, Kids TLC in Olathe, and the Guidance Center up in Northeast Kansas, CMHC.
Very good. Any working group members, regular members that I missed on that list there? If not, as a reminder, for each of our topic-specific meetings, the groups have the opportunity to invite additional those with supplemental expertise to weigh in on the topic of the day. And so we're joined by one additional expert who will weigh in throughout the discussion today, but want to first invite Krista Postai to introduce herself, share maybe just a little bit about your background and some of the experience you bring to this. And if there's any initial recommendations that you'd like to toss out to the group as we start our meeting, those are more than welcome as well. Krista?
Thank you. I'm flattered to be called an expert, especially this early in the morning. And greetings to Greg, who is a fellow Southeast Kansas ite, and I appreciate he's got a PSU t-shirt on. So go Gorillas. I am Krista Postai. I am CEO and founder of the Community Health Center of Southeast Kansas, based in Pittsburgh. We are now, we started out in a double wide trailer, and now we're one of the largest health centers in the country. We're in the top 25 with about 55,000 patients in Oklahoma and Kansas. So we did move over into another state, which has been an interesting experience. They have a whole different approach to everything. I'm also a member of the Sunflower Foundation Board, and the Kansas Health Information Network Board, as well as the Kansas Physicians and Providers Engaged in Prevention Research, KPEPR, much easier to say its initials than its name. I'm also a grant writer and a grant reviewer for HRSA. So I've had the opportunity to read a lot of workforce grants by other states. It's very impressive what's going on elsewhere. It's also very competitive. And that's me in a nutshell. I'm a KU grad in journalism. So it just proves you can get a job in journalism, even if journalism is dead.
Thank you, Krista. I'm a K-State grad, but still I will thank you very much for joining us here this morning and for those introductory comments. All right, with that, I will have us jump into our agenda here. And so this is where it will be perhaps helpful to have that WG1 crosswalk agency doc open. I'm going to share a more colorful version of that on the screen shortly. So you all should be seeing that on my screen. And again, your version should look like this, but without the colors. So when I sent out this document to the group, a question posed was basically, what on this list do we not need to cover? So in the interest of wanting to spend as much time as possible discussing the recommendations that will be most critical to our mission of modernizing the behavioral health system, the question posed to the group is kind of what here do we not need to address? So those flagged in red on my screen are those that I heard back that maybe we don't need to spend time on. If anyone in the group has concerns with kind of crossing these off our list, it's not a big deal at all. We'll drop it right back in. But want to pause here to give people a chance to take a look at the 3 recommendations in red and let me know if they need to go back on our list. So those recommendations have to do the tier 3 recommendation related to front end staffing from the Child Welfare System Task Force. From the Mental Health Task Force, recommendation 5.1, a workforce study, recommended to be removed, as well as recommendation 5.2 related to peer support. Any questions or concerns with removing those recommendations from the list of those that the group will consider?
This is Charlie Bartlett with KDAD's Adult Services. Peer support is certainly something that we are trying to expand and build and have found very valuable, both in the SUD world and dealing in the mental health world. And we are trying to increase those services across the state and build capacity for those services.
Okay, so I'm hearing a recommendation that this one go back on our list for discussion.
Well, this is Will Warrens. I'm not saying that it shouldn't, but I'm just saying I think the state has done a good job in 2020 between the 10% raise, between the conversations about opening the rates to others, and the incentives that have been given to the MCOs. That's the only reason why we're thinking maybe it doesn't need to be discussed by this group, not because we don't value it, but because there's been excellent work being done on it. Just my 2 cents.
Representative Carpenter, did you have a comment there?
Yes, on the workforce study, I suppose I'm just curious why. I don't believe we need a study, but it certainly is an issue and is going to continue to be an issue for years to come in all across our social services programs. So I don't really care about a study, but it certainly is going to be front and center as far as an issue going forward. So that's all.
Can I say something?
Yeah, go ahead.
Well, I just want to say, I don't disagree with the last two comments, but I think when I look through this document, there's so much in there that if we want our work to be useful, we're going to have to narrow it down some and really focus on the high priority issues. That's all.
Okay, so this is, go ahead, Krista.
This is Chris Postai. When I was reading through this, the workforce study, I see value in that, especially as I look at what other states are doing in terms of competing for federal funding. Data is very important, and the more that you can define your needs and your gap, the more likely you are going to attract additional support and funding. So unless the state already has a good handle on data, I think that's a great idea to pursue. But if it's being done, I think more power to it.
Yeah, Charlie or someone else at KDADS, could you speak to whether or not any of the data that might be surfaced in a workforce study, is any of that information already in hand?
This is Charlie again. I think that it's in progress, but things continue to change, especially with the COVID issues and what's happening with tele and the development of the right services to provide that in our state, as well as the skills needed to do that effectively by the clinicians.
Okay. Any other discussion on these three recommendations that had been proposed to be removed? I'll say what I'm hearing is there's at least interest in discussing further the workforce study and the peer support. So at this point, we would be considering striking from the consideration for this group, the front end staffing. Okay. Thank you. That is all helpful discussion. And with that, I'm going to put a new document on our screen. This should look familiar. This is the recommendation rubric that we discussed at our most recent meeting. And what we will do now is the recommendations that are kind of still open for consideration related to this topic. We're going to go through and see if any updates need to be made to those recommendations, and then score them for both ease of implementation on the left, score it from 1 to 10, and then score it for a potential for high impact on the right after looking at kind of those considerations listed under each. So as you'll see on our screen, the first recommendation that's up for discussion here is a tier 1 recommendation related to workforce. This is from the Child Welfare System Task Force. We'll give you a moment to read that recommendation. But the first question I'd like to pose for the group is this recommendation part of what it would take to have a modernized behavioral health system in our state? Alternatively, are there changes or updates to this recommendations that would make it more effective or do more towards modernizing the behavioral health system?
And this is Andy Brown with KDADS. I suppose it would make maybe more sense to me if it was investing in the mental health system workforce.
Make that change.
This is Greg Hennon with Fort County. I would echo Andy's observation. That was my kind of gut reaction or initial reaction to your question, but being a CMHC, I can get kind of tunnel visioned, but since we are talking about mental health or behavioral health reform, while the child welfare system certainly is an important system that runs tandem with us, it doesn't drive the resources. In fact, it can sometimes compete for the resources that we need to have an effective system.
Very good. So I've made that change in the recommendation language. With this slightly revised recommendation, I wonder if the group is interested to discuss what ease of implementation could look like for this recommendation. Recognizing that it is.
This is Senator Alley. The question I have is, under ease of implementation, would you say we're already in a program since we've been in it for a year already?
Any agency staff care to comment how you'd characterize this recommendation in terms of, is this existing work that's going on that's ongoing, or would this require new programs launching?
This is Andy Brown with KDADS, and I think it's a little bit of both. I suspect that in order to really develop new workforce in Kansas, it's going to require additional investment beyond what we're currently funding. And so some of those might look like pilot programs or a program change, I suppose.
And this is Charles Bartlett with KDADS, echoing that. And I think also from our discussion last time, looking also at rural and frontier areas where the workforce is much more difficult to recruit and fund.
Great. What about cost? Would cost be a barrier to this implementation?
This is Senator Alley again. Looking at our budget for next year, I'd say cost has to be considered.
Mm-hmm.
Yeah, I would point out we're looking at a 10-year plan though. So, I mean, we don't necessarily have to make this investment in the upcoming legislative session.
What about strategies for continuity? The groups talked about the importance of sustainability in these recommendations. Would this recommendation be one that you would consider to be sustainable?
This is Will Warrens. I guess the way I read the recommendation, I don't think sustainability is built into the recommendation. Sustainability is going to be ongoing work and ongoing difficulties, but much needed.
Mm-hmm.
think it's encapsulated in the recommendation.
Mm-hmm. So to follow up on that, is there a change that we should make to the recommendation language to try to, I don't know, build more sustainability into kind of the infrastructure of what we'd be proposing here?
This is Senator Alley again. One of the things I see missing in this document was the measurement of success.
Made that note there. We'll maybe figure out language in our kind of second pass through, but can certainly make an edit to the recommendation that there should be, you know, measurement accompanied to it.
I mean, this is well warranted. And nothing's for sure, but I guess you could say should make a long-term investment plan. You know, I mean, maybe that's one way of making a minor change.
Okay. Then kind of our last category of questions under ease of implementation. Which of the following mechanisms may affect how achievable this recommendation would be? So what types of changes would would implementing this recommendation require? Legislative session action? Would there be any federal approval processes, et cetera?
This is Andy with KDADS, and I suspect you'd be looking at legislative session, agency budget development, and grant cycles.
Great. With those considerations in mind, is someone willing to toss out a score for ease of implementation for this recommendation? So as a reminder, we're not counting check boxes or anything. It's very much a qualitative process. As a reminder, a score of 10 is a recommendation that would be very easy to implement. A score of 1 would be the most challenging to implement, with the idea that, you know, when we look back at our recommendations, those that are very easy to implement and have a very high impact kind of across the board, those would be the highest scoring. They would have the largest value associated with them. So how would we score this from 1 to 10 for ease of implementation? Representative Carpenter, is your hand raised?
Well, I've been advancing this workforce deal, not just for mental health, but across the board for all social programs for a couple of years. Everybody knows it's a problem. I mean, you'd have to be living under a rock to not realize that we have problems across the board, but it sure is hard to get people to buy into these situations. It is almost bizarre to me that it's that hard to get any traction with folks. So I would think that it would be very difficult, like a 1, but nevertheless, it is so important as we look through our nursing facilities, through all of our social programs, and we've just got to keep the fire underneath this issue.
Okay, I heard a 1 in there, so I'll put that on the screen. Any discussion? Does 1 seem, how's that land for everyone? 1 seem about right?
This is Krista with Community Health, and I have a question. I concur with the 1, but my question is recruit from where? I think as a provider, we can't find anybody trained. The new graduates are coming out unprepared for the profession. So I'm not sure this is comprehensive enough. We can't recruit from other states. We need to grow our own. So I wondered, and I've read the whole document, but I haven't had the chance to absorb it like others have, but recruit from where? They're not out there, at least not in rural Kansas.
This is Greg with Fork County. I think that's a really good point. It may need to be increased funding for training and recruitment, retention. We are losing a lot of our workforce into Oklahoma. Yesterday, got another resignation of someone that's going, one of our therapists is going to work for a CCBHC down in Oklahoma. I now have 8 therapy position open and 0 applicants.
It's a seller's market. It's not a buyer's market. This is true. We're fighting over a very small number of people.
I'd like to say something that just, one of my frustrations over all the years I dealt with these issues is that we have a strong support, particularly in the legislature, for a capitalist system, but then seem to totally ignore how that system works when it comes to talking about hiring staff. And, you know, it's what a willing buyer pays a willing seller, and it really comes down to money. But it's just an observation, because I understand why this is a one. And it just is a real frustrating thing to work with year after year of not having staff, but nobody willing to invest the money necessary to make it happen.
Thank you for those comments.
And
So I
this
was
is-
making, go ahead.
This is Charles Bartlett again. I also think with what Krista just said about recruitment and growing our own, we need to invest in promotion, and that's going down into the high school level and get people interested in public services, doing this work and providing these services. Because most people, when they leave high school and enter college with that investment, they have a career in mind when they go there. And we need to get more people invested in providing public services through mental health and substance use disorders.
Great, thank you. With that discussion in mind, I wonder if we could now shift our attention to the right-hand column, potential for high impact. We won't go item by item in terms of checkboxes, but take a look at the things listed as considerations there, and tell me what you think. What will the impact be like?
This is Greg with Fort County Mental Health Center. My bias is that the potential for impact is really quite high. Just throwing a number out there, I would say 8, and I don't know if that's the right number, but that's just what my gut tells me. The challenge that we have is that if I have a full complement of therapists and case managers working, and we're doing the right thing for all of the clients out there, things are going to go very well in their lives, and it's difficult for us to demonstrate what didn't happen because of our effectiveness when you're talking about social services. And when you can't demonstrate what didn't happen because of our good work, people will say, well, there's no need, we can reduce funding. So that's kind of the cycle that social services gets into, is how do you prove what didn't happen because of the good work you did?
This is Andy Brown with KDADS again, and I would say one of the things that states that have implemented the CCBHC systems has experienced is a lot of success in terms of their workforce development, and also the access to care, that the flexibility of having that opportunity to invest in workforce provides. So, I mean, one of the, when we critically look at the access to care issue in Kansas, workforce development is one of the primary impacts around that, I believe. So I'd echo an 8 or maybe even a 9 in terms of impact.
Okay. Any other special populations that we should be sure to note here, as far as those who would be impacted by an expanded workforce or expanded support for workforce development?
This is Will Warrens. I also, second what Andy said about the CCBHC, and I didn't know if that warranted a federal approval process check mark over on the left-hand side of the page. Because if we're doing CCBHC, that may be, that may necessitate that as well.
And this is Greg with Fort County again. To answer your question about special populations, children, low income individuals, and limited English proficient would all be impacted by a full workforce.
Great. Maybe do last call for comments on this recommendation. If not, I'll move us on to the next one just in the interest of time. Okay.
This is Charles Bartlett again. To echo what Greg said, I think when we look at foster care, I think having a proper workforce adds to the preventive pieces in parenting, which then would lead to less foster care needs.
Great. Made that note as well. Okay. Thank you for that discussion. To continue on, the next recommendation that we'll be looking to score here reads to recommend the number of clinical supervision hours required of addiction counselors to obtain clinical licensure be reduced from 4,000 to 3,000, similar to the reduction in clinical hours of social workers. So first question, kind of staying at the highest level for the group, is this recommendation an important part of what it would take to have a modernized behavioral health system in our state?
This is Krista at Community Health. The change in the social work requirement made a huge impact on us overnight. I can't imagine it would not help in the area of addiction. I think it would impact the front line, certainly. And I think would be more attractive to attract a bigger workforce. The 4,000 hours is pretty intimidating to most people, especially if you have to pay to have that supervision.
Charles Bartlett again, I certainly would agree. And the other thing I want to bring forward is that supervision and the number of hours in supervision become even more difficult in the rural and frontier areas where sometimes a person is needing to travel for supervision. And there's some restraints on supervision that has to be in person as opposed to some of the tele, which also puts restraints on it. And so the cost, again, I think this would make an incentive for a good workforce development.
Great, thank you for those comments. But now would direct us, go ahead.
Thank you, Carly. This is Greg with Fort County. The only comment I would have about the recommendation is I don't know that we want to onesie twosie this in terms of social workers 1 year, addiction counselors the next, and then some version of behavioral health counselors year number 3. Should we expand that recommendation to say addiction and behavioral health counselors so that it's not just the LACs, but also the marriage and family therapists and the clinical psychotherapists and the, so that all master's level people that have those supervision requirements have a level playing field essentially. The 3,000 hours is actually work hours. It's 1,500, and you don't need to put this in the recommendation, just for information, it's 1,500 direct service hours. So if I have to get 1,500 client hours to get my license, the extra 1,000 of just having worked, whether it involves clients or not, is really of no value. So I think the 4,000 to 3,000 is really appropriate, but I think it should go across to every licensed credential that can go into that clinical level of practice.
Great, thank you. Would direct the group to the ease of implementation column. We won't go item by item, but what check boxes would you have me kind of describe this recommendation with?
This is Greg with Fort County. I think it's as simple as a legislative action.
Yeah, I mean, there would be a regulatory process also at BSRB once legislative action's been taken.
Thank you.
I might just add, this is Barbara Bellett, that we say legislative session, but actually that could prove to be a lot more difficult than you think it is. Because once you come up with one or two things, then people come down with 3 or 4 and they want to know why they're not included. So you'd have to really think about that, because we tried, I think at one point we did it with social workers. And somebody said, well, wait a minute, I know about this one. And what does that belong? So I think we'd have to make it narrow, or we'd have to figure out how you're going to be even more inclusive.
To that point, are there any additional language changes that we should make to the recommendation so that it is, to Representative Ballard's point, as inclusive as the group intends for it to be?
Let me just ask you, if you look at the top, you say consider, are you looking at program change, which is, you know, it says here the easiest. I don't think cost is really where the problem is. It's just that other groups will think they belong there too. So, I mean, we have to make sure if we're going to do it, that we're inclusive enough that we haven't left out a group, or they will create enough confusion that it won't even get through it. Because often the speaker will say, when you work it out and it's ready for us, we'll take it up. I see, Greg, you're smiling. You know what I mean.
So Barbara, we did broaden it to all behavioral health counselors. Originally it was just addiction. Mm-hmm. What are you thinking of that we haven't included?
Well, I'm not sure. I mean, I'm just trying to make sure we're going through to say what else could be out there. I'm not saying don't do it. I just want to make sure that we have covered all the bases instead of making that something that holds it up.
Got it.
This is Representative Lynn. Are there any issues with reciprocity? Is it pretty standard 4,000 to 3,000 then throughout the states?
Sarah, is your hand raised in regard to that question?
So this is Andy Brown with KDADS, and my understanding, and Greg, you can jump in and correct me if I'm wrong about this, but we don't actually have any reciprocity with other states. Kansas requires that in order to practice in Kansas, you have to have a Kansas license, and in Missouri requires to practice in Missouri, you have to have a Missouri license. And so people that live on the border in Kansas City have to be duly licensed in both states separately.
This is Greg with 4 County. That is accurate. That reciprocity does not exist across the state lines with our license. However, I think the point about what other states require in terms of getting their therapists licensed at the clinical level, that 3,000 number is more in line with Oklahoma and Missouri. I don't know about Colorado or Nebraska.
This is Sarah Fertig with KDHE. I was going to ask whether we have anybody representing the Behavioral Sciences Regulatory Board in this work group. They might have some input on this proposal. And if we don't, I might suggest that they be invited to comment on this.
This is Senator Alley. I think that's a great idea, because where did the 4,000 hours come from in the beginning? And we've been trying to work with bringing people across the state lines. If there are 4,000 hours in Missouri or 4,000 hours in Oklahoma, and we reduce hours, or it's opposite, we go to 3,000 and they can't go back across the state line if they need to. So we need to find out where that 4,000 came from, and is that a hard number?
That's a good point, Senator. And I would also, that's another reason why I think somebody from BSRB would be very helpful to weigh in on this proposal. And in addition, if there was legislation to adjust the criteria for licensure, that is something that you would need some buy-in from the board. Otherwise, they would probably come out against it if they don't have some advance notice and the opportunity for buy-in.
For that, I'll make, I don't believe we have that membership represented in this group, so I'll make that note. Anyone interested to throw out a score for ease of implementation for us from 1 to 10?
I'd say 8.
Okay, pausing a moment just to see if anyone disagrees. I've typed an 8. Okay, then we'll direct the group to a quick discussion on its potential for high impact. Looking at our list of considerations here on the right-hand side, what boxes or notes will it be important for me to make here? Would this recommendation benefit a large population?
I would think it'd affect the whole state. Actually, if you do that, it'd have an impact across the entire state.
I would agree with that.
Any special populations I should note?
Well, the one below that says it would affect those disproportionately impacted by the issue. It could possibly address inequities because, you know, we're a lot different in care in rural versus urban, and more crowded in urban. So I think it would address inequities and maybe provide a better opportunity besides our community mental health centers out there for people to get care.
And then lastly, any notes we should make regarding cost savings? Would a recommendation like this produce savings in any other areas?
Right now, I would say I don't know if it would be cost savings, but the question I would ask, does it have to be? Because this may be a case of meeting needs out there that we know exist, but we're trying to come up with different approaches and different opportunities for people to get this care. So I'm not sure about the savings, but I think the benefits in other areas would outweigh the savings.
Yeah. What about a score? Is anyone willing to toss out a score for potential for high impact, 1 to 10?
Seems like I'm hanging with 8 this morning, so if it was 7-7, I'd go play the lottery. But you know, I said I would say I'd say like 8. I don't think it's all the way to the top because we really don't know. But I think we all know there is a need. So
Great. I've typed an 8. We'll pause a moment there. See how that sits with everyone. If there's not any last comments on this recommendation, I saw some thumbs up, so I'll move us along to the next one. Next recommendation we're looking at has to do with supporting initiatives to provide tuition reimbursement for addiction counselors, equal to those provided to other behavioral health professionals. A comment I got in advance from the group was that there might be potential for this recommendation to be combined with others. So let me put that colorful version of the crosswalk back on my screen. The note that I got from a working group member was that these recommendations in purple could potentially be combined. So we'll overview those quickly, but would be interested to hear what discussion the group would have around combining these recommendations into one. So the top one in purple having to do with tuition reimbursement for addiction counselors, the children's subcommittee recommendation about adequate workforce compensation and reimbursement rates. Specifically, the children's subcommittee recommendation does include, I think, reimbursement for implementing family engagement practices. And then the workforce development recommendation from the Substance Use Disorder Task Force had to do with kind of most generally implementing workforce development programs to increase capacity of addiction professions. Is there interest from the group in combining those recommendations? And if so, what would a combined recommendation look like?
This is Charles Bartlett. I'm sorry, go ahead.
This is Senator Alley, and the question I had was, how much tuition reimbursement are we going to be offering?
Is anyone familiar with the work of the Governor's Behavioral Health Services Planning Council? Do we know if they've set a level of reimbursement? Or is it a more general recommendation?
This is Charles Bartlett. I was liaison for that group when they made that recommendation. It was more of a general, and part of it, why it was asking that in SUD is that the pay parity for counselors in SUD is much lower than it usually is for social workers and others in the mental health field. And so it was a general recommendation that it was very expensive for a person to get into the field because of the cost of schooling and the differences in salaries of those workers.
This is Senator Alley again. The reason I was mentioning that is because on the rural opportunity zone, tuition reimbursement is a big portion of that. And perhaps this can be combined with that in those rural and frontier counties. The definition, I would like to go ask a question, and maybe not for this discussion, but how do you define a frontier county? Because that question has not been answered in the RAWS worksheet.
So at KDADS, we usually use the federal definition for frontier counties, and I think that's like one person for every 10 square miles or something like that. I don't remember exactly. Charlie, do you recall what that is? Or
I don't have it on the top of my head, but I'm looking it up right now, and I'll be able to give it to you here in a little bit.
Yeah.
And the reason, this is Senator Alley again, and the reason I was asking that question was perhaps if that's really a concern about getting the professionals into our rural and our frontier counties particularly, maybe we could increase the amount of tuition reimbursement for those frontier counties. And that needs to be considered if that's part of the goal. Thank you.
That's a good idea. This is Barbara Ballard. That's a good idea, because if that is what you call your more needed, or whatever we want to say, area, harder to attract people for that position. We do that in many areas. If you want rural, we do a little bit more, or we offer a grade of incentive. We do it in our schools. If you're short on music teachers or science teachers or math teachers, you try to attract more because there's more demand. So yeah, I can see that working.
Yeah, and this is Andy Brown with KDADS again. So the definition for frontier counties are people, it's less than 6 persons per square mile. So it's not even 1 per 10, it's less than 6 per square mile.
Wow.
And just to expand on that, just overall definitions that were recommended or set is that rural are 6 or designated as 6 to 19.9 per square mile. Semi-urban are 40 to 149.9 per square mile, and urban are designated as 150 people per square mile.
Sarah, is your hand raised?
Yeah, I was actually trying to unraise my hand, but I did have something to add. Just for the work group's information, the Board of Emergency Medical Services for a number of years has received an appropriations proviso that allows them to fund what they refer to as their education incentive grant, where folks who decide that they want to become a paramedic or an EMT can receive up to, I think, $800 towards their education costs. And in exchange for that, they must agree to work for a rural or frontier service, ambulance service for 2 years. So there is, that is one type of recruitment and retention program that currently exists. So I just wanted to make sure the work group was aware of it. That's one model that's been in place for a number of years.
Yeah, that's perhaps a helpful starting point to kind of circle back to what recommendation, looking at the 3 that we're potentially interested to combine here, what recommendation is the group interested to make? So I heard discussion about reimbursement for frontier areas as we're parsing out the difference between rural and frontier. Sounds like from Director Ferdig's information, EMS included in their program, both of those designations. So the question for the group, what type of recommendation here in regard to, it sounds like tuition support is the group interested to make?
So this is Andy Brown with KDADS again, and there are a lot of loan forgiveness programs available for health professional shortage areas around the state, which I think are through HRSA. I'm not 100% positive about which federal agency it is, but I know that those are oftentimes used to help attract workforce to rural areas. And so it's not an upfront investment in the student, but it's a reimbursement once the student comes to the community to work.
This is Krista with Community Health. Andy's accurate, but it's only the higher credentialed professions that qualify. Typically, addiction counselors would not be covered by that. They just added pharmacists recently because of their role in the opioid crisis. But there's not very much tuition reimbursement out there for this level of professional, which is unfortunate. So I had a question. The statement is equal to what the other behavioral health folks get. How much tuition support is there out there? I'm not familiar with a lot of it, independent of different institutions like schools and scholarships.
This is Greg with Fork County. I'm not familiar with any other than the National Health Services Corps, which is, they do the designations, you know, for the health professional shortage areas.
Right.
And that's a federal program. And Krista, you're right. It's for the higher degree
LSCSWs,
clinical social workers, PhD psychologists, and MDs. So yeah, for your standard master's level candidate and for addiction counselors, I'm not aware of tuition reimbursement.
So equal to is really not saying much. If there isn't any, equalizing them will not incentivize anybody to go into the field.
Yeah, they're already equal at 0.
Yeah.
That's true.
This is Will Warrens. They do have the state loan repayment program, which has multiple professions included, including, well, you can see it on the KDHE website, but licensed professional counselor, licensed master's addiction counselor, licensed clinical social worker, as well as a wide variety of other professions.
But I am familiar with that. And do we know how many people actually benefit from that? My understanding is the funding is not substantial, but they are eligible.
The funding's competitive. I mean, we have a physician assistant at the Guidance Center who has been the recipient of that, I think going on 5 years, and it's been great for her, but it is stressful and competitive to get one of those awards.
So as far as crafting these into a new recommendation, I think I heard several things from the group. Please jump in where I'm wrong, or if anyone has other components, please add those. So increase reimbursement, or maybe establish reimbursement, tuition reimbursement for frontier areas for master's level candidates and addiction counselors.
I like that. Oh, go ahead. Who was next, Carly?
I think I saw a hand raised for Representative Carpenter if he still had a comment to make there.
Representative Carpenter here. I think that any of these tuition situations, depending on how much money they receive, should include minimum time working in Kansas.
Isn't it a minimum time working in the frontier area?
That's fine.
Because I'm thinking they'll all come to Kansas City.
And that may be fine, but we need to target that. We just can't be giving money away for tuition to train someone to go to another state.
Okay.
And Representative Ballard.
Thank you. I agree with that comment from Representative Carpenter. I think they need to have some kind of ties. You know, our medical, school, we pay their tuition, but we also have an obligation that would go. So I think that would do it. The other thing is we may look at, especially I think Senator Alley mentioned maybe an incentive. We may want to look at maybe a pilot program our way as an incentive, especially in those areas that are hard to get people to come out and work, that maybe see if whatever we come up with in our pilot program, is it effective? And if so, then we can decide we want to make it more permanent. That might be another possibility to answer what he was suggesting as well.
This is Senator Alley again. What I was referencing was the RAWS program. They do have a tuition reimbursement in the RAWS program. Perhaps if we could look at what they recommend and look at their requirements and kind of keep it similar to what they have. They do not presently have a difference between the frontier and the rural, but I think if we're trying to get them in the frontier program, we need to maybe look at that also.
Great, thanks for the clarification. That was good.
That would be a helpful maybe decision point for the group. Are we interested to make this recommendation for rural and frontier areas, or just frontier areas as the focus?
Yeah, well, this is Andy Brown with KDADS, and so adding rural would almost double the number of counties where this program would be eligible. So you go from about 36 to about 70 counties.
And this is Charles Bartlett again. I think across the board, though, there is a shortage of substance use counselors in all areas of the state, and not just in the frontier.
Okay, I've made that change in the recommendation then. And then to circle back to one piece in what Representative Ballard was listing, the pilot program I heard you describe. Could you say more about what you mean by areas that are hard to serve? If we were to give it, at least some examples of those.
A totally different scenario, but it took us a long time before we could get any kind of rural treatment on dental services in the state. And it was just difficult because in those areas, you know, a dentist could be serving up to a radius of 400 miles. And if that dentist should leave, there was no one to take, you know, the dentist's place or anything. So I just wondered if we would look at an area that is very difficult to have mental health services, because they don't either live in the community, they have to drive in, or they may have to stay during the week, go home on the weekend or whatever, that we may try different kinds of a pilot program to see if that would help that community receive the services they want, you know. But we'd have to identify which are the most difficult areas for us to provide mental health services in the state.
Okay. I have some draft language on the screen here. It certainly needs to be cleaned up, but at the highest level, can you check my work? Are there any major components that we've discussed that you see are missing from this new combined recommendation on the screen?
This is Krista. I don't know how to incorporate this or whether we should, but when you're talking about serving those areas, oftentimes there's not a real practice opportunity there. So telemedicine is making a huge difference in those hard to reach areas. And that has been kind of controversial when it comes to several other programs. Would that qualify? If you're serving a frontier county via tele, but you're not physically there, would that also qualify? So if we're going to modernize, I don't want to overlook the role of telehealth, especially out in our more remote areas out in Western Kansas.
I would agree with that, Krista. That's a good idea. And you know, and even that is kind of like a pilot program in a way to see if it's providing those services. I mean, you can't get a body out there, but you can get services out there. Yeah.
Yes.
We'll have one of our meetings will be wholly focused on telehealth. So I'll flag this, I'll flag that component for that discussion. Dawn, is your hand raised?
Yes, I just wanted to say that I think I'm not disagreeing with the importance of telehealth, but I think it's a separate alternative that really, you know, isn't part of this. That I think it would be looked at differently, because I think this is looking at getting people out there and getting them to work. Telehealth is just a different option and a different way of going about it. And I don't know, to me, it seems like to give tuition benefits to somebody who then lives in Lawrence and does telehealth out west would defeat the purpose. But anyway, that's just my comment.
And this is Krista. National Health Service Corps just modified, you have to, in return for the loan repayment, you have to devote 3 to 4 years of service. They've just modified their requirements to allow that service to include telehealth because they were excluding a lot of people. So at a federal level, they've just updated that. So I'm not saying we should, but we should at least consider it. Oftentimes in some of those areas, there isn't enough of a practice opportunity to make a living when you're that remote. The only way you can get service is via tele. But I do agree it's a separate concept. I just don't want to forget it because it screwed it. It was a barrier in the National Service Corps that they have just lifted last year.
Dawn, did you have a follow-up conversation there? And then we'll maybe have this be our last comment on this topic, and then we'll move along in the interest of time.
No, I'm trying to figure out how to unraise my hand.
Very good. Well, thank you for that discussion. We will, I think, look at one last, in the interest of time, we're going to maybe use our recommendation rubric to describe one last recommendation, and then we will get into some discussion of new recommendations. Okay, so and I bring us to this one that you see on the screen here, recommendation 5.3 from, I believe, the Mental Health Task Force. I think it's a related concept to some that we've just been talking about. It is regarding the state loan repayment program, and the recommendation is to require a report on increasing the number of psychiatrists and psychiatric nurses. Is this recommendation an important part of what it would take to have a modernized behavioral health system in our state?
Yes. I would, as Barbara said, I would say yes, definitely. Psychiatrists have turned out to be the most difficult in order to recruit. You know, I'm on the board of Bert Nash, and I mean, it took us over 3 years to really find one. The one we have now drives in from Kansas City. And so, I mean, if we're having trouble and we're somewhat on the urban thing, what happens to people that are really out there that really need services? We just don't have them. And I mean, I know you know, people say it's the cost and most people can't afford it, but in some cases, you know, these people are serving 3 or 4 different centers.
I think there's a couple with their hand raised. Representative Carpenter, did you have a comment there? You might be muted.
It's early in the morning, I guess. Representative Carpenter here, who would we task to put this report together for us?
Your thoughts on that? I think one option could be asking the agency to identify who should best put that report together, but we'll leave that up to the group.
I suppose anybody knows which agency it is that manages the program.
This is Krista. Since these are medical professions, would that be something a medical school should be tasked with? I know they've done reports on primary care, like a KU School of Medicine. I know they'd have ideas on how to, it would all require funding, but we don't produce very many psychiatrists in Kansas.
Made that note. Don, is your hand raised?
Yes, I was just going to say, I would suggest it be KDADs, because they could just survey the providers. There aren't that many, you know, the CMHCs, hospitals with psychiatric wards. They just sort of survey them periodically to find out where they stand.
This is Andy with KDADS, and it does look like it's a program with Kansas Department of Health and Environment.
Yeah, it says it on the website, KDHE, Office of Primary Care and Rural Health.
So would the group be interested to direct this recommendation to KDHE then? Okay, seeing some nodding. Okay.
This is Krista. I don't want to overlook the educational institutions. We have approached one of the universities about adding a psychiatric nurse practitioner program because we're only producing about 4 or 6, maybe 10 a year in the state of Kansas. And so we have approached a school of nursing about considering that. So if our goal is to increase the number, I don't want to exclude those who can make that happen. They know what they need to make. I've been told what they need to do that. and it's a lot of money, and a faculty, and it's a lot of money. So I work with primary care. They're a great group. I think they can assess it there, but I would not want to overlook the educational institutions that produce these folks, because they're going to be more specific and precise about what they need.
Great.
Primary
Thank you.
care
So
is
the note that
good
I've
at
made-
surveying, though. They can survey, but I think we already know the answer of how many psychiatrists and nurse practitioners we have licensed in the state of Kansas. I think that answer is already out there because I've used it before. It's not very many.
Okay, so to clarify, if we're making a modification here, we're noting that KDHE manages this existing state loan program, and they should conduct this study that the group would be requesting, or work with an educational institution to conduct this study, with the idea that that partnership would be an important one to establish if if a program will get off the ground. Okay.
You've said it very well.
So I'll make that change. We will not score this at this time. What we'll do, there's just a couple of recommendations that we haven't got to scoring. So what you'll get from me is a quick Qualtrics survey where you'll go through and toggle some of these buttons for me. And then at the beginning of our next meeting, I'll show you kind of all of the individual responses that I received. We'll check in quickly for consensus, and then we'll get into the topic for that discussion. What I would encourage us to look at now in our remaining meeting time is an opportunity for new recommendations beyond those that have been previously developed. So what you should see on the top of your screen here, these are the barriers that this group previously identified related to this topic that we didn't think was captured in any of our existing recommendations. So again, opportunity here is to propose totally new recommendations. And I'd be happy for the conversation to start with, any of the barriers you see listed on the screen.
This is
let's
Will
start
Warren.
the conversation wherever there's, yeah.
Yeah, this is Will Warrens. And when Greg Hennon and I talked about this, we felt like one stood out, and that is the diverse workforce, deserved conversation.
I agree.
How could we craft a recommendation there? I think in previous discussion, the group identified at least 3 groups that would be important to encourage kind of development in the workforce, and those of variety of races, LGBTQ, and those who would be able to serve those with limited English proficiency. How could we craft a recommendation to support that workforce? Don, is your hand raised?
Yeah, again, it was from the last time, and I just don't find the button to lower it. I was going to say, this is one where maybe some more study is needed, because, I guess a perception I've always had, working in this for a number of years, is I think part of what it is money's part of it, but also the lack of, entertainment, restaurants, just, the kind of things you get in a city. When you get further out there, you lack all of that. And you know what I mean? I think it'd be interesting to find out to what extent those are the issues that are real problematic, that it's not just money, but just, a lack of anything to do. And I'm not saying.
Sarah, is your hand raised? So you might be muted.
This is Krista, just to echo what's just been said. Studies show that less than 3% of new physicians want to work in areas with less than 25,000 population. That's pretty much most of Kansas, except for the big urban areas. So it's a problem in general. No one wants to live in small town Kansas, except me and Greg. And COVID really has changed the atmosphere quite a bit. There are no restaurants, there's nothing to do right now. But it hasn't made recruitment easier.
So
It also does
recommendation
limit your
related,
diversity, though. It does really limit your access to diversity.
so I'm hearing a recommendation to study this issue further. Is the group landing on that as our recommendation here to understand more about the barriers related to a diverse workforce? Or is there something more, is there something in addition to that the group's interested to recommend at this time?
This is Charles Bartlett again. I agree with the study of the gaps and et cetera, but I think also this gets back to promotion and promoting people into the workforce that represent those populations through education and just social promotion of working in those fields.
Charlie, I agree with you. We're also seeing that that's going back to 6th grade. People are making their minds up in 6th grade. And so high school is almost too late. So I do think we need to really do a lot more educationally to encourage young kids to think about this profession.
Okay. I've made note of a couple draft recommendations there based on those comments. If anyone has additions or corrections to those, one would be to study the gaps in the workforce to better identify opportunities to address the lack of diversity in the workforce. And then a second recommendation I heard was to consider opportunities to promote the behavioral health workforce among those. Don't remember how old middle schoolers are, but I'm thinking about age 12 to 18 based on your comment, Krista.
Good. Yep, you're right. Okay. I don't remember much about middle school either. Everybody wanted to be a teacher, though. Everybody's going to grow up and be teachers.
Looking at some of the other barriers the group has listed, are there other new recommendations the group is interested to discuss at this point related to workforce? The specific one, I think there was quite a bit of discussion last time, was around the issue of insufficient pay in Kansas compared to some of our bordering states. Don't know if that's something the group is interested to discuss further.
This is Greg with Fork County. One of the things that I'm seeing is I've got people living in small rural communities exiting my organization to go into Oklahoma to live in small rural communities. And the only difference is that Oklahoma as a state has certified all of their behavioral health providers as CCBHCs, and we simply can't compete. They're paying $20,000 more a year for a therapist than I can pay. So I think we do have to look at that as a barrier, and we aren't going to have a diverse workforce, and I'm not going to have a workforce if that kind of outflow continues. So unless we can change our compensation level, we're just going to keep bleeding into the neighboring states.
Sarah, is your hand related to this?
It is. One question I would have is whether it's specifically noted that Missouri and Oklahoma pay more. I do wonder if their Medicaid reimbursement rates are higher than Kansas's. I can't say I know that off the top of my head. Krista might have potentially some insight on that since you also work in Oklahoma, but that could have something to do with insufficient pay in Kansas if their rates are higher.
I think you can, I think we can compete pay wise. I'm not sure. I know everybody, all the dentists get paid less in Missouri. So they send all their patients over to Kansas on Medicaid. I'm not sure that's the problem. I think it's the reimbursement. We're reimbursed as an FQHC. So it makes a psychiatrist find affordable for us. If you're fee for service, you cannot cover their costs. They cannot work enough to cover their cost. So no matter what the pay is, conventional reimbursement is insufficient, whether it's commercial or Medicaid or Medicare. How some states have gotten around it is, or how some organizations have gotten around it is a per member per month reimbursement, which is what we saw in Tennessee, Greg, when we went to Knoxville. They were able to hire psychiatrists because they were getting basically a monthly stipend to retain them. So I think it's the reimbursement system and not necessarily the amount, just the whole way we're reimbursed. Fee for service will not cover it for those high priced professions. It's true of psychologists too.
In Tennessee, was that per member per month reimbursement through the Medicaid program?
It was.
Super.
And that's how Knoxville did it, which if you've not been to Knoxville to see the Cherokee Health System, they have created a sustainable system, which is a combination FQHC and Community Mental Health Center. So they're leveraging their reimbursement models financially effectively.
Is that a recommendation this group would be interested to consider? Per member, if I'm going to reflect it back correctly, a per member per month payment from Medicaid to support access to psychiatry?
Well, I think that would have an impact on workforce, but again, the CCBHC certification shows some pretty impressive outcomes on the patient side. So thinking beyond just this individual topic, certainly I agree with Krista that the reimbursement methodology that the FQHCs have is what makes it possible. But on the behavioral health side, the CCBHC model seems to be where the success is being found, both for the patient and for the organization's workforce in Oklahoma and Missouri.
And this is Will Warren's. Amount is also an issue if you look at the CPT codes that the medical staff bill, but that gets into a complicated phenomenon that I personally haven't been weighing in on because I know that funding is something that we're coming to. So I've been holding off talking about that.
Greg, if I recall though, they also got, Knoxville got the enhanced reimbursement for services. They also got the per member per month fee. So it was on top of it. It was a twofer.
Okay, thank you. I didn't realize that.
So it was gravy, which is why they could have a psychiatrist on call 7 days a week and available for counseling or medication.
I want to check in quickly. Representative Carpenter, I apologize. I think you've had your hand raised for a while here. Did you have a comment?
Yes, Representative Carpenter here. I will tell you though that money is not the only issue or a major issue. I think it's back to some of the folks commented about populations under 25,000. We have worked diligently in social services budget with Representative Ballard to raise the pay out at Larned State Hospital, and it is significantly higher. And I think that the last report that we had at CanCare Oversight was we'd been able to lower our vacancy rate by like 2 or 3%. And we're talking about probably over the space of the last 2 years, 15% increase in pay. So it's not just the pay, it's just difficulty. I think if you offered a lot of these folks $100,000 a year, they still wouldn't go to rural Kansas. So just my take on that.
Thank you. And in the interest of our time here, to Dr. Warren's point, I'm going to flag this issue. Our next meeting will be on funding and accessibility. So I think this is maybe a good place to press pause on this issue, and we'll take it back up at our next meeting on the topic of funding and accessibility, as I think there's a lot more conversation than we have time in our kind of final 2 minutes here this morning that would be valuable. Just administratively, wanted to let the group know a couple different things. One, this is likely on the radar for everyone, but want to be sure everyone knows the special committee meeting. The next special committee meeting will be on Monday. That will be available by live stream through the Kansas legislature. Also, you have a scheduling poll from me. I'm going to send out calendar appointments, hopefully, today. So if you have not completed that doodle scheduling poll for the next meetings of this group, please do so as soon as possible. Going to get those next couple of meetings scheduled here. And then once we get that next meeting scheduled, which will be in the next, about the next 10 days or so, the topic that we'll take up at that meeting is on funding and accessibility. I think I have some supplemental experts that you all had identified to join us for that conversation. But if there are others, please let me know, send me an email, and I will be sure to extend an invitation to them. Additionally, I think I mentioned this while we were discussing existing recommendations. You will receive from me a brief Qualtrics survey where you'll just be asked to do a quick scoring of the recommendations that we didn't have a chance to talk through today. That's to give us a starting point. At the beginning of our next meeting, we'll review all of that information, see where we are in terms of consensus, and then dive into the discussion on funding and accessibility. So I show 10 o'clock. So in the interest of ending on time, I want to extend a special thank you to Krista for joining our discussion here today. Your input was extremely valuable. Yeah, I'm seeing other thumbs up in the video windows. So thank you to Krista, and thank you to everyone else for joining us. But unless there are final questions I can answer, we'll consider us adjourned.